Hi everyone, I'm Dr. Sharanti. We'll be discussing about a practical approach to thyroid nodules. By end of this video, you will be able to know what are thyroid nodules, how to approach any patient, which investigations to order. Introduction. Thyroid nodules are disorganized growth of thyroid gland, thyroid cells that produce a mass in the thyroid gland. It is so common that even 60% of the individuals they will likely to have one or more nodules, and only 5% among these will come out to be a malignant. They are mostly benign and asymptomatic. Even in cancer, the small indolent thyroidal that can be safely managed conservatively. So, missing a high risk cancer or overtreating a low risk nodule both can be harmful for the patient. So, it is very important for the physician to know about what actually the clinical approach has to be. Having one case scenario, a 32-year female, she presented in OPD and felt a new neck mass which was non-tender. You ordered thyroid profile which came out to be normal. USG neck was performed that showed 1.1 centimeter hypoechoic, taller than wider nodule, which was labeled as euthyroids 5. At the end of this video, you will be able to answer this very confidently. Now, the initial investigation. In every case, you have to go through a thorough personal and family history with physical evaluation. This is important to rule out any risk factors that are present for malignancy. In history, any symptoms suggestive of obstruction, past history of irradiation, family history of any thyroid cancer, and on examination, you have to describe the nature of nodule, whether it is large, fixed, firm, which are always suggestive of malignancy, and any lymphadenopathy. Now, the first investigation, primary investigation in every patient of thyroid nodule is to get a thyroid function testing. Now, serum TSH thyroid profile is measured in all the cases. If TSH levels are low or undetectable, that suggests the possibility of toxic autonomously working nodules. So in that case, we get thyroid scintigraphy. That will suggest whether a hot nodule is there or cold nodule is there. If hottest nodules are present, they rule out the malignancy. Now, serum TSH levels, if they are high or normal, there are increased chances of cancerous nodules. So they have to be considered for further investigations. Now, in this slide, seeing the approach, in any case of thyroid nodule, we have to take the history, examination, and obviously thyroid function test. If TSH is decreased, we get scintigraphy and hot and cold nodules, and if there is cold nodule, that need to be stratified further. And if TSH comes out to be normal or elevated, again USG is done to stratify the lesion. So the second important investigation is thyroid ultrasound. This is the first line approach. This stratify the nodule according to euthyroids. The report mentions the nodule size, location, ultrasonography features, expected risk of malignancy, and what matters in the report is the echogenicity, shape, margins, and calcification. Solid appearance, increased vascularity, microcalcifications, irregular margins, and absence of halo. These are the features suggestive of malignancy. But a more practical approach is to classify the nodules according to euthyroid scores. Now, according to this score, there are classes. First, there is no nodule. Second, euthyroid 2 is benign. It is pure cystic or entirely spongiform, and risk of malignancy is 0%. So we need not to get any FNAC in these kind of cases. And we have to follow up such cases. And if the lesion is more than 10 mm, ultrasonography is done every 3 to 5 yearly to see any increase in the size or nature of nodule. Now, euthyroid 3, that is low risk, oval, smooth, iso or hypoechoic with no risk factors. Estimated risk of malignancy is 2 to 4%. And when to do FNAC is when the lesion is more than 20 mm. If the lesion is between 10 to 20 mm, we generally don't do biopsy. We just follow up the patient every 3 to 5 yearly. Now, euthyroid 4, intermediate risk, oval, smooth, mildly hypoechoic, no high risk features. Estimated risk of malignancy is 6 to 17%, and we do FNAC if the lesion is more than 15 mm. If it is less than 15 mm, we simply follow up the patient 1 yearly. Thyroid 5, it is high risk with any one of the following features: non-oval, taller than wide, irregular margins, microcalcifications, marked hypoechogenicity. These are basically solid ones, and the risk of malignancy is around 26 to 87%. When to do FNAC is if the lesion is more than 10 mm, and if the lesion is less than 10 mm, we follow up the patient every 6 monthly to 1 yearly. Now, the second thing is FNAC. As we have already discussed, that when FNAC has to be done in thyroid 5, that is high risk cases if it is more than 10 mm, thyroid 4, intermediate risk if it is more than 15 mm, and thyroid 3, low risk if it is more than 20 mm. So, cytology is the primary determinant of management. USG guided FNAC is recommended. FNAC classification, it is very important, and it is done by Bethesda method for reporting thyroid cytopathology, which is widely accepted method for cytology reporting. Royal College of Pathologists use Thai categories for reporting. Both the systems use 6 categories but with different names. Now, this table will give more clarity about both of the systems. Bethesda classification, if it is class 1, that is non-diagnostic, and risk of malignancy is 5 to 10%. Class 2, benign, and risk of malignancy is 0 to 3%. Class 3, atypia of undetermined significance or follicular lesion of undetermined significance with a risk of malignancy of around 10 to 30%. Bethesda class 4, follicular neoplasm or suspicion for follicular neoplasm that carries risk of malignancy of around 25 to 40%. Bethesda 5, suspicious of malignancy that carries a risk of 50 to 75%, and Bethesda class 6, that is malignant, 97 to 99% risk of malignancy. On comparison of Thai classification, we have Thai 1 or 1C, that is cystic lesion, which is non-diagnostic. Thai 2, benign. Thai 3A, atypia of undetermined significance. Thai 3F, follicular neoplasm or suspicion for follicular neoplasm. Thai 4, suspicion of malignancy, and Thai 5 of malignant. Now comes the most important part, that is the follow-up and management. I have divided it in 2 parts. If the nodule is not undergoing any FNAC, and then when to follow up, that is T2, lesions of more than 10 mm, they are to be re-evaluated in every 3 to 5 yearly, but less than 10 mm, they need no further evaluation. T3, that is low risk, 5 to 10 mm, no further evaluation is required, and 10 to 20 mm, re-evaluate in 3 to 5 years. T4, intermediate, less than 15 mm, re-evaluate in 1 year. T5, high risk, less than 10 mm, re-evaluate every 6 to 12 monthly. If suspicious nodules or worrisome location, consider FNAC. Now, after FNAC, these are based on Bethesda. Bethesda result 1, non-diagnostic. The typical next step will be to repeat FNAC and follow up. If still non-diagnostic, re-evaluate within 1 year or consider surgery. Lesion number Bethesda class 2, benign. Surveillance is required if the lesion is T3 thyroid more than 20 mm or T4 more than 115 mm. USG is done every 3 to 5 yearly. If more than T5 more than 10 mm, repeat FNAC. After 2 benign cytology, no further biopsy is needed. Bethesda class 3, repeat FNAC or molecular testing if available. Repeat if repeat comes out to be class 3 and T3 more than 10 mm, re-evaluate within 1 year. If T4 or T5 more than 10 mm, surgery or active surveillance is required, and class 4 and 5 we recommend surgery. This was all about the video. Thank you.